Okay. ACL patient. So we use bone marrow aspirate concentrate to repopulate the collagen of the graft with cellular volume. So for the BMA harvest, we prep the leg into the field. Fibular head is our target. Tibial tubercle is our guideline for the medial face. Infrapatellar tendon, tibial tubercle attachment, fibular head, the medial face is right here. So I'll move the skin over just a little bit so that our incision and the skin aren't the same plane. There's a little bit of mobile skin over the medial face. Knife. I'll make a little poke hole because I don't want a skin plug within my cannula. So the cannula is loaded. It's been flushed with ACDA. Fibular head. Take again, you got my poke hole. Pull the medial face over. Medial face, aiming towards the fibular head. Pull the cannula out. Stick the trocar down in there to free up or frack that zone for us. Syringes have already been loaded with ACDA, pulled all the way down. You can see the bone marrow starting to come out. We can turn that if we need to. Key is to stabilize this so you don't pull the catheter out. It's easy to move because again we're making a round hole. It's not like a jam sheety where you're malleting in something to fracture through the bone. We're drilling a hole so we have a round catheter through a round hole so we don't get the micro fracturing around the entry portal, which means you don't have the risk of a subperiosteal hematoma, cuts down your risk of infection, the post-procedure pain. You can actually push and touch right over this area because the draw's a little difficult. I'll keep my other cannula in my hand, so if it ends up being difficult or it clogs up a little, I kind of recannulize that area. This is a really nice, easy, steady flow. The key with the draw is to limit platelet activation and clotting, which means that that fact alone is responsible for some of the design in the cannula. Make it a less traumatic draw, lower the cytokine and the platelet cell activation and cellular wall lysis, which causes the clots and lowers your cell count. The only reason to do this is to try to get as high a cell count as possible. And again, the advantage of bone marrow mesenchymal cells are that they're being served to us in a slurry of growth factors. Bone marrow is 97% whole blood. The growth factors that we're spinning down with the concentration of the stem cells, fibroblastic growth factor, transforming growth factor beta, VEGF, are crucial to the collagen matrix revascularization of our graft, which is the whole reason for doing this. Survivorship of the allograft, incorporation of the allograft, health of the joint fluid following the procedure. Get another syringe, get a little bit of fat in there. Recannulized that. 60 cc draw is a lot. And again, we're causing an increase in the retrograde blood flow as we do this to wash those encrypted cells into our draw zone and into our syringe, and eventually to be concentrated and injected back into our graft. Okay. And still pretty decent, easy flow. All right. When we first started doing these tibia draws, no one really thought we'd be able to get this kind of volume. Again, screw back in the trocar, twist, pull it out, stabilize the knee. Again, the skin, the poke hole's back here, skin goes over top of it. And we're done.